Thank you. We'll rush to two more presentations. The third is by Medicine 4, John Kurian. That it's entitled "It's Just Start by Shredding." Make it brief.
Good morning, everyone. Today I am presenting in behalf of Medicine 4. It's just start by shredding. So, case history 35-year-old male, Mr. Y from Kadapa, who works as an auto driver, presented with fever. For 6 days, which was high grade, intermittent, and released with medications, and cough for 6 days with minimal expectoration. There was no breathlessness, no dysuria, no headache, or no associated symptoms. So, past history, he underwent hemorrhoidectomy surgery in December 2022. In January 2023, he developed insidious onset of progressive weakness of bilateral upper and lower limb associated with pain and tingling. He was suspected to have autoimmune encephalitis from outside hospital, and he was started on pulse, methyl prednisolone, and later changed to oral prednisolone drug X. And he then developed new onset of hair loss around after 2 weeks after starting on this medication, and saw to a dermatologist from outside hospital, where he was given some topical agents. Coming to personal history, he has normal bowel bladder habits, no weight loss or no weight or appetite loss, non-smoker, and does not consume alcohol also. Treatment history: immediately after starting the fever, he went to outside local hospital, and where he was treated for the past 5 days before coming here. His treatment and medicines include injection meropenem, metronidazole, acyclovir, fluconazole, and GCSF. So, clinical examination on arrival, he was conscious oriented. He was tachycardic and tachypneic. Pulse rate of 120 per minute, respiratory rate of 32. Blood pressure was on arrival was 80/50, and saturation was 92%. Temperature, he was febrile on arrival, 100 degree Fahrenheit, and his GCS was 15. There was mild pallor present, no victus, no clubbing, no cyanosis, no lymphadenopathy, and there was actually literally no hair on the patients when he came here. There's papular rash involving trunk and back, sparing extremities. And other system examination, other than respiratory system, which showed minimal crabs on the both lower zone, other systems were within normal limit. So, syndrome, acute febrile illness with shock and ARDS. So we sent up for our routine investigation. HB was 7.5, total count of 500 with neutrophils of 0, and platelet was 27,000. Creatinine was normal, 0.55. SGOT and SGPT were normal, and other LFT markers are also normal. We sent for cultures, viral markers, reticulocyte count, which was 0.3%. Vitamin B12 and folic acid were within normal limit. LDH was 143. Bone marrow showed hypoplastic marrow, and galtamin test was 0.23. And we did a CT thorax which showed features of consolidation, probable bacterial or fungal etiology. And he was treated with the broad spectrum antibiotics, antifungals, and GCSF. So, what caused febrile neutropenia and this hair fall? Drug X is an antimetabolite which has an immunosuppression as side effects, and some studies which have showed that it has got a hair fall also associated with it. So we sent for a thiopurine methyl transferase enzyme, and it was 9.1, which was low compared to general population. So, any idea what is drug X? Hmm. Anyway, the answer was already in the question. It's almost first hint was there in the question itself. The TPMT enzyme was low in this patient, so it was azathioprine. Azathioprine is an anti-metabolite, 1-methyl 5-nitro 5-metazole derivative of thioguanine, is a purine mimic anti-metabolite immunosuppressive agent that acts as an antagonist of purine metabolism. It causes inhibition of DNA, RNA, and protein synthesis. So the mechanism which is happening is azathioprine is actually a non-enzymatically converted to 6-mercaptide purine, and it will be basically acted upon by 3 enzymes. Actually, first enzyme is the main enzyme, which is hypoxanthine phosphoribosylate transferase. So in that this enzyme will convert 6-mercaptide purine into mercaptide purine nucleotides, and it will be later converted to thioguanine nucleotide, which is the main metabolic end product, which causes the myelosuppression. And the other enzyme is the TPMT. TPMT is act on 6-mercaptide purine, and it will be converted into methyl mercaptide purine. So and xanthine oxidase, it will act upon and causes a thiouric acid production. So if TPMT or xanthine oxidase is inhibited anyway, and the other main enzyme will get more activated, and thioguanine nucleotides will be produced more and will cause a severe myelosuppression. So what is the problem with this patient? So thiopurine as methyl transferase inactivates azathioprine. So it has 2 functional alleles. If the 2 functional alleles were absent, it can cause a life-threatening myelosuppression when treated with azathioprine. And if there is 1 non-functional allele, it can cause significant side effect, but not life-threatening. And there is another mutation called NUDIS15. It is more associated in Asian population compared to European population, and also associated with the severe azathioprine toxicity. So there was this article published in JP where we have assessed what it is done in North India. There was no studies done in South India to assess the thiopurine as methyl transferase mutation prevalence in India, North India, where they have 176 subjects. Only 3 patients had a TPMT mutation came positive. That too only recessive. No, both alleles were not absent. Only one non-functional allele was there. And compared to when studied, the people TPMT mutation was prevalence is low in North Indian adult patients. It is 1.7%. Compared to Western population, it was almost 10%. So before starting on azathioprine, it is mandatory in Western Europe, where they have to test it for TPMT mutation. And there is a clinical case study where azathioprine induced severe myelosuppression accompanied by massive hair loss and painful oral ulcers in autoimmune hepatitis patient with the NUDIS15 minor variant. And NUDIS15 is another mutation which is more seen in Japanese population or Asian population, where after starting on azathioprine, we can see severe azathioprine myelosuppression, and there is this case study actually showed hair loss also, and with painful oral ulcers, because all this antimetabolic will act on most of the highly replicating cells. So hair cells and squamous cells will have an effect and cause oral ulcers and hair loss. So how to assess drug toxicity? So in our patient, we have sent for thiopurine methyl transferase enzyme. It was came to low, and which metabolic end product 6-methyl mercaptide purine and thioguanine levels can be also sent to assess the drug toxicity. For this patient, it was little low because the patient has already stopped the drug when he had the hair fall, and he came to us after 2 weeks. So when we consulted with our pharmacology lab, they said that even though the patient has stopped the drugs 2 weeks back, and it hasn't met a cutoff since it is just below the cutoff. That means it has definitely developed a toxicity in the earlier. And suppose if you want to start a patient on a azathioprine in future also, so since we are not doing a genetic test, what basic test we can do is laboratory testing of a CBC LFT is performed weekly for at least for the first 4 weeks, then once in 2 weeks for the another 3 months, and at least once in every 3 months thereafter. So our patient actually, after starting on drug, within 2 weeks itself, he had developed a severe toxicity symptom, actually, at least as clinically. But no one was there to at least check on the toxicity of drug also. But then after that, he developed a febrile neutropenia and presented as a complication. And our patient, we are treated with antibiotics and antifungals, and he got symptomatically improved, and counts also started improving. And his metabolic encephalopathy workup is still pending. We have done an MRI, and we have to further evaluate on why the patient was initially started on azathioprine in the first place itself. And the patients since the patients are clinically improved, we discharge the patient and plan to follow up in patient OPD basis.
Thank you, John. Any questions? Yes, Amit.
Patient has a history of use of azathioprine.
And we don't know what it was.
Why was he started on that?
Outside, ma'am, the patient has been.
Why?
At that time, he was diagnosed with autoimmune encephalitis from outside hospital, and
What are the symptoms?
symptoms, numbness and right side weakness were there.
So what's the cause of that?
We are they have done a evaluation. We are still on.
I mean, that was the presumptive diagnosis outside staff. We did a full evaluations, then were not convinced. So he has been discharged on on just a follow-up. So he had a stormy course. He went through all those things. But his initial presentation outside iffy diagnosis of autoimmune encephalitis on immunosuppressive.
This is my question. What happened was that outside it present these symptoms.
No, but what was the chronology? Usually when you say bilateral upper and lower limb weak, it was post an infection, which is what it seems like.
He actually didn't clinically complain of any weakness. This was all documented from outside. What he complains is of insomnia. Recurrent insomnia is what he
It must
complains
have gone for
of.
something.
And pain and tingling over by that upper and lower limbs. Why he went outside. Following that, outside they did a lot of EMG, NCD, everything, and they said this weakness, they diagnosed facial weakness also, which is a relative setting. They sent an autoimmune panel that Casper and NG1 antibody came positive. So they diagnosed autoimmune encephalitis. But clinically, the only complaint he had was insomnia, no seizures, no psychiatric manifestation, nothing. So we evaluate that further. We sent the panel surveyed. But clinically, he was pulsed with for 5 days and started. After that, all the symptoms are resolved by the clinic. So what do we need for that? We have sent him to neuro to see if anything further needs to do. We've done an ONG, we've done NCD. What is our NCD? What is our NCD show? No. And evening you're not sure. But are we done the panel? We outside they did a PET before they started and pulsed. So we didn't say here we've done a CT and negative. That PET was negative. So
Okay, we are already 9. Zagre, can you do it in 5 minutes? Okay, good.